Thank you. I'd like to thank the Swedish Science Foundation and the organizers for having me come back again for this wonderful meeting and presentation. I'm always delighted to come among my peers and also my mentors to give a review, as I call it. My section is more of a review for almost everybody here, and to discuss and share a discussion as to whether anything has changed in the management of the thoracolumbar spine in terms of trauma management. I'll dive right in. I'll skip some slides. It won't affect any CME, as I've discussed in the interest of time. So, as we all know, it's 15% of all major thoracolumbar injuries occur per year in the U.S. It's about 5,000 of those have significant neurological deficits, and it's about 25% of all traumatic fractures in young adults. Mostly 83% of these patients have true thoracic fractures, have another major injury. Chest trauma, pelvic, lower limb fractures are very common. And of these, about 75% of them will have neurological deficits. So why is the thoracolumbar spine injured? As we aware, this is mostly in the T11, thoracic vertebra 11 to the lumbar vertebra L2, which is a transition zone. And you're moving from a stiff, kyphotic, immobile, and stable spine to a lordotic. There's an abrupt change, and hence that area is subject to rotational shear forces. So essentially, stability is important when we're talking about spine trauma, and also day-to-day maintenance of alignment, as we had an exceptionally revealing talk prior to this talk by Dr. Dubusset. The anterior column provides most of the axial load at that level of interest, which is thoracolumbar spine, and most of the thoracolumbar junction injuries are caused by indirect trauma. The combination of flexion, axial load, lateral compression, and extension can result in injury. However, as you can see, the appearance on static imaging does not really tell you what happened at the moment of injury. And of course, our history taken and also details as to the mechanism of impact, etc., is more important and has altered the way in which I treat some patients. If I feel the forces are too great, sometimes I go beyond any classification that I'm going to share with you here. There's no universally agreed upon classification system, but ideally, we would want it to be simple, include a vast majority of injuries, reflect mechanism of injury, and determine treatment options based on the classification, and also you can determine prognosis. This has been a work in progress amongst multiple groups that have taken this on between the AO, between subgroups in the United States and Europe. But essentially, we all start with the three-column theory, which is the anterior column, starting with the anterior one half of the vertebral body to the annulus, including the disc space, the middle column proceeding from there, and then the posterior column, including the pedicles, ligamentum, and the inter and supraspinous ligaments. This is a good foundation to have, as I tell everybody, to have this concept in your head, because that helps you understand and also interpret forces that are at work. In example, a compression fracture where the ligament and the posterior elements are intact and the canal is intact, to a stable burst fracture where you have loss of height, canal occlusion, there's some angulation and comminution, but no posterior column injury, to unstable burst fracture where there's posterior column injury and some, most often, a hint of spinal cord injury, which sometimes is very subtle, and it could be a change in even bar and bladder pattern, but maybe ascribed as normal. Of course, with flexion distraction injury and also chance fractures, these are more of an extensive injury, with all the most significant one of extensive fractures would include fracture dislocations. So in an attempt to have a uniform language to share amongst providers, to discuss injury and also to help with patient management, the AO group started in 1994 with a 10-year review of over 1,400 images and also in different institutions, came up with a classification system based on three major groups, A, B, and C. A involved mostly compression, and also you had impaction fractures, split fractures, burst fractures, as opposed to B, where you had posterior ligament, posterior osseous disruption, and also with C, where it was a more extensive injury, rotational injuries, and also distraction injuries involved. However, this is rather complex. It's comprehensive but complex. The neurological component of it was not well described or even included there. Last year, Dr. Chapman said they're working on it. It's coming out, so I'm keeping my fingers crossed, but I haven't seen any literature on that. However, we do have since 2005 the thoracolumbar injury severity score. Most residents currently in institutions of training between orthopedics and also neurosurgery go by this, and there are members of the crowd that were listed up here in the faculty also that were participants in this. And most important idea of this was the introduction of the neurological status as part of the classification, a three-part description where it was a point system. You had a translational component, translation and rotational component, distraction injury, versus a compression fracture which included axial, flexion, and burst component. And then you also had the posterior soft tissue point system where it was intact, it was a 0. And if it was indeterminate, suspected, you give it a 2, versus if it was injured, you give it a 3. And this was all evaluated with standard imaging. And then you had the neurologic point system with nerve root injury, chorda equina, and whether it was complete or incomplete. So there are also, with any classification system, you have to have qualifiers which model it a little bit. These injuries are not very well defined. It's a spectrum with multiple overlaps. So you can have a beautiful classification system, and but then if you have an open fracture, overlying burns, patient cannot be braced for any conservative treatment. And I'll mention again, patients with abnormal bone disease, ankylosing spondylitis, DISH, metabolic bone disease, and concomitant other fractures, age, general health may lead you to one treatment algorithm versus the other. Of course, timing of treatment also matters if they had other injuries. So ideally, in the TLIC system, 3 points or less was a non-operative, bearing any other qualifiers. Injuries with 4 points was more of left to you to apply the qualifiers versus your own assessment based on the history and also the mechanism of injury, etc. And definitely injuries 5 points or more, it was more of a way to lead you more into doing surgery. First, you have to identify the fracture morphology, assign points to it, assess the integrity of the posterior ligamentous complex. You assign points, and then you assess the neurological status to assign points, and then you sort of gauge your clinical qualifiers to provide treatment. I say this, and I like to repeat this because of most trauma scenarios require some systemic guidance as to what to do. And these days in the trauma setting, there are other multiple groups involved, trauma, other consulting groups, and it's nice to have something to lead you one way or the other down the path of treatment, and to communicate to other groups so they can also understand what you're doing. It's no longer moving towards the mighty surgeon approach, but it's more of a system-based approach. And quite frankly, so far, this has been the most helpful in applying these algorithms, mostly for communication and to guide treatment. So an example will be a 35-year-old gentleman who fell from a ladder. He had a burst fracture, which will be assigned 2 points. He's neurologically intact, 0 points. The posterior ligamentous complex is intact. He gets a total score of 2 points. We would say he's a non-operative. Now, if he had an open wound, that changes significantly what you may plan to do. Again, you also have a 38-year-old gentleman who's in an MVA, a motor vehicle accident. He's belted. He does have complete paraplegia. Burst fracture, 2 points. He gets a total of 7 points after you add all the other components to it. And this has been validated. It was validated a year after it came out. 90% of surgeons agreed with the treatment recommendations after reviewing imaging. So there is some confidence to this. And this was a multi-group, multi-specialty group that agreed, forwarded by Dr. Harrop. So it's important to familiarize yourself with classification system. Use one, get one, use one. It makes it important for communication, for coverage in terms of medical legal issues, and also you have to also consider the patient-related issues, and your own preference will be what you want to choose to use. But obviously, your treatment goals remain the same: prevent further neurological deterioration, stabilize the spine. Alignment is important, and to help with early mobilization and to minimize pain and deformity. So it comes to some of the controversial issues now. Thoracolumbar injury options. When do you brace? When don't you brace? How do you determine that? And I sort of went through all of that to help bring up the discussion. But literally, when you have an unstable burst fracture, surgery is for the majority. It is highly improbable. I'll only do that temporarily. I'll brace them temporarily if by putting them prone, the patient may have other systemic complications. So if you have to have a open aortic injury surgery, XLAP, I have to wait my turn, but the patient is not going anywhere. They're bedridden, they're in ICU, they're in a rotator bed, I can wait. But typically, to help with mobilization, I want to stabilize an unstable burst fracture. Certainly, if they have once they are hemodynamically stable and our ABCs are in check, I would like to know whether I can move forward as soon as possible before tissues are going to be in the way. Again, with flexion distraction injury, we certainly want to stabilize the posterior elements. Some of the areas that I've gotten into trouble have been people with severe flexion distraction injury in the setting of currently new lateral approaches where you can do plating, is that we don't address where the injury is, which is the posterior elements. And essentially, these constructs tend to fail quickly, sometimes even before their post-op visit. So again, I also say that non-operative does not always equal conservative treatment. Most people can only tolerate a certain amount of immobilization. The non-operative patient also requires significant follow-up. Seeing them 8 to 12 weeks after you put a brace on them may lead to some disasters. You have to see them soon. If they're morbidly obese, compliance, and also if they have even a hint of neurological injury, I highly recommend not bracing them and following them, and bracing them and not following them sooner rather than later. So a lot of studies have compared both the anterior and posterior surgery, but invariably, even when we looked at level of evidence, if you don't ignore where the significant injury is. If you do an anterior surgery where somebody has mostly a flexion distraction injury, your construct will have issues. Beyond that, if you address where the damage is or where the trauma is, your constructs tend to remain stable if you take in consideration bone morphology and also technique. Okay, more points of fixation are required for poor bone quality since they tend to fill with a short segment. It's particularly with posterior instrumentation. And often you may require anterior column support. These are some of my early failures when I thought I was smarter than my trainee and my mentors. People with dish. You don't want to do somebody with dish fracture, no matter how many ACDF levels you do, no matter how many anterior construct you do, if they have a fracture through and through in 3 column, they need support. I wouldn't mind doing an ACDF, but you have to support it in the back. And this was a concept that was hard for a lot of people who trained before this became our instrumentation, caught up with our treatment strategies. This was a lot of failures that I also repaired and fixed. And definitely my greatest pain will be patients with rheumatoid arthritis prior to those who have started disease-modifying agents. It's just terribly hard, as we all know, and certainly malnourished patients can be augmented in clinic. I'm going to skip over some of our cases here for the interest of time and to make sure that other speakers have a chance to speak. But this is a final picture of what Rod used to do as a trainee. That's Dr. Shaffrey, our mentor. This was, I think, the final case that Rod did before he was pushed out of UVA to come to Seattle. But typically these days, what's been nouveau has been a increase in the use of the extreme lateral approach to treat thoracolumbar burst fractures. But it's important that this is an advanced step. This is not your usual disc procedure, and I encourage people to do a lot of the usual disc minimum invasive lateral access procedure before they attempt to fix this in the thoracolumbar posture. But the techniques remain the same. Key points remain the same. Flex the table after the patient is secure. Do not move the C-arm. Retract the handles that directed posteriorly when operating in the retroperitoneal space, as opposed to the anteriorly when operating in pleural cavity. And essentially, you have to secure the segmental vessels early in surgery. This is very important. Doing this in Pittsburgh in the setting of a burst fracture is to identify the segmental vessels because they will be displaced and partially torn. So it is not your usual lateral access disc surgery if you want to attempt it. However, you can, with our current instrumentation system, multiple systems, you can have an elegant short construct preserving dynamic mobility of the spine in the appropriate patient, in the young skier, young ATV patient, as opposed to my grandma. I wouldn't want you to do this for my grandma. Her bones are too frail to support this. And sometimes you can also even get a stronger plating system. So it becomes a controversy. Brace versus surgery. Multiple length of evidence papers have been written about this. But what's really a point of consternation now with the advancement of instrumentation, with the ease of performing surgery, is if you know that you're not going to get good compliance, if you know that somebody is prone to fail, their posterior elements are not stable, it's still hard to decide whether to operate on a neurologically intact but grossly borderline unstable patient. And the question is, if they're not going to put on your brace, are they going to come to your clinic? You're still on the hook. Should they have a neurological injury? Time wasted, medical legally is not returned to you if you're vindicated. So I always say, be careful. Sometimes if the patient is not interested in surgery, again, as you always remember, immense documentation by yourself, not your PA, including yourself, discussing it extensively is more important. But there are certain techniques of the percutaneous system that I'm not going to go into because we're going to cover that a lot in the lab. But there are also advantages and disadvantages, which include sometimes when you're doing these percutaneous, it's getting less and less because of advanced training, and also it's become more common. But the instrumentation, things sort of like difficulty in compressing and distraction are going away as the instrumentation system becomes better and better. And also the loss of tactile feel and visual anatomy is improved with 3D navigation, but it's a learning curve, and I encourage people not to do it without proctoring the first time. But the MIS thoracolumbar, minimum invasive spine thoracolumbar trauma indications include burst fractures, the whole gamut of unstable spine, dislocations, distraction injuries. In conclusion, there are no major changes yet. The classification system in the last 10 years have sort of remained where they are. There is a uniform language for mechanism of injury. The surgery for the neurologically intact patient remains. debatable. But currently, I just urge everybody to invest in their trauma service to help them get the right algorithm, to get the right appropriate treatment for their patients. You have to lead the charge when you do have a thoracolumbar injury, because I have had enough patients be discharged without me being consulted. Thank you.
Hey, thanks for visiting the Seattle Science Foundation YouTube channel. To find videos just like this one, click here. To subscribe to our channel, click right here. Or check out our website here, or see what we do by clicking right here. Thanks again for watching.